So we're talking about management of diabetes type 2. Um, Really, if those oral medications don't work, there's injectable medications that are not insulin based, and then there's also insulin based um, medications as well. Sometimes type 2 diabetes just can't be controlled by anything but insulin itself, trying to overload the receptors that your body has. Um, Often, somebody gets diagnosed with diabetes when they come in for just a yearly medical examination, and they end up doing a blood draw, and they find that they have high blood glucose levels, some other things, recurrent infections, especially for women, recurrent UTIs from dumping all of that sugar into their urine can really irritate them quite a bit. Changes in vision, and then numbness in your feet. Some symptoms of hyperglycemia. So hyper, again, is when the blood glucose levels get too high. The patient tends to be in a altered mental status from several different combined problems. In type 1 diabetes, the high blood glucose leads to that ketoacidosis that occurs with dehydration because you're trying to get rid of some of that sugar, and so you pee it out, and that makes you super dehydrated. Type 2 diabetes, you tend to get a different syndrome. It's called nonketotic hyperosmolar syndrome. It's a state of dehydration because of all the fluids from the systems that go out through the kidneys. It leads to a fluid imbalance, but this tends not to have those ketones because you're not actually breaking down the glycogen. If a patient has hyperglycemia for a long length of time, there's several different consequences that they could face. They have problems with healing, so they oftentimes have wounds that just don't heal the way that they're supposed to, and they get numbness in their hands and feet as well from a condition called peripheral neuropathy. And because of that, they can have sores and whatnot on their feet that they can't feel, that end up not healing well, and then can lead to some pretty severe infections and sepsis. So the big thing that they do at their annual checkup is they end up getting their feet checked to make sure that everything is okay. You can have blindness, you can have renal failure, gastric motility problems, which often leads to just somebody being nauseous or vomiting more frequently than they should. For that type 2 diabetes, when you have high blood sugar, this is what it's: hyperosmolar, hyperglycemic, nonketotic syndrome. I forgot they added in that nonketotic. So you have high blood sugar, altered mental status, severe dehydration, so you're just super thirsty. You end up having super dark, concentrated urine. You have visual and sensory deficits. You may have partial paralysis or muscle weakness. And then patients are also pretty prone to having some seizures. So patients try to keep up with the dehydration that occurs by drinking more, but they truly just can't get enough fluid in because their blood sugar is so high. So we do try to hydrate them, but as an EMT basic, you can't start an IV. So this becomes a time when ALS might be necessary to be called. So now the other end of the spectrum, what happens when your blood sugar goes too low? So this is something that we definitely need to correct very, very quickly. And this can happen because of a patient that has injected too much insulin, has taken an oral medication that stimulates the pancreas to produce more insulin. It can be that they have not eaten, or they've been sick, So when your blood glucose is rapidly taken out of your blood because you have more insulin than you do glucose, your glucose levels are going to fall to the point where it truly may not be sufficient enough to supply your brain. Your brain needs glucose and oxygen to survive. So now you're pulling one of those things away. So what happens? Well, your mental status is going to start to decline. Does that necessarily mean you go into a coma? No, not necessarily. Some patients just act very different from how they normally are as a person. They may become very aggressive or display unusual behavior. Oftentimes, they do start to get a little bit tired, and then they can progress to unconsciousness and permanent brain damage if we don't fix the situation. So, we've already talked about some common reasons why the signs and symptoms can develop very, very quickly. So somebody that has hyperglycemia, it takes a little while for those signs to start building up. Hypoglycemia doesn't take much time at all. Sometimes, a matter of minutes can make the difference. So this is going to be normal to shallow rapid respirations, pale, cool, clammy skin, dizziness, headache, rapid pulse, normal, sometimes low blood pressure, that altered mental status, anxious or combative behavior, seizure, fainting, coma, weakness on one side of the body. So it actually can mimic a stroke. That's why any patient that we suspect is having a stroke, we do check a blood sugar on. And then just rapid changes in your mental status. They might be there and talking to you 1 minute and it just tanks very, very, very quickly. So what we need to do is we need to give the patient glucose. Now, as a EMT basic, your options are oral glucose. So the patient has to be awake and able to actually swallow it. If you can't do that for your patient, then it's necessary to get ALS on scene so we can get some IV glucose going. For our patient assessment, especially the scene size up, just like everything else, but now because we know that patients with diabetes often use syringes, we want to make sure that we look around and be very cautious for when we're putting our hands down, because they're not so worried about their own needles, but we definitely don't want to try and get stuck by one of them. So kind of be alert for clues, syringes, insulin bottles, etc., because oftentimes they may be confused enough that they can't tell us what's going on, but we can look around and get more information from the scene. You want to try and determine that mechanism of injury or that nature of illness, if possible. A lot of times that's going to be truly talking to your patient to figure that out. You'll form your general impression. How does the patient actually look? Are they anxious, restless, apathetic, meaning they just don't have any sort of feelings towards anything? Are they irritable? Are they interacting appropriately with their environment? And then we're going to move into our ABC to identify life threats. So we will talk to our patient if we can. Your patient may have no idea that they have diabetes. So don't just start with that and run with that. Still stay with your steps. So we'll start with airway. Patients that are having any sort of problem breathing, they're having inadequate respirations, their SpO2 is 94 or below, go ahead and throw them on some oxygen. Hyperglycemic patients, we talked about those Kussmaul's respirations. So they may be breathing in that different pattern. They may have a sweet kind of fruity smell on the breath because that's those ketones coming out. Not everybody can actually smell ketones. I'm one of those people that cannot smell ketones. I've had people that are severely acidotic in DKA breathe right in my face to where other people are going, oh, that smells super sweet. I can't smell it at all. Patients, if they're hypoglycemic, their respirations are not going to be super off. It can be normal to a little bit shallow, rapid, but not super bad. So you want to open the airway. If they're unconscious, insert the appropriate adjunct for them, administer oxygen, and then continue to assess them throughout the call. For circulatory status, we always look at the skin. So if they're dry and warm, they're hyperglycemic. If they are moist and pale, then hypoglycemia is more likely. If they have a rapid, weak pulse, then they may have symptomatic hypoglycemia. It's going to be weak because remember, they're super dehydrated, so they're not going to have enough fluid to produce a really good, strong pulse. Now, that's if they're progressed into hypoglycemia, if they're symptomatic. You want to go ahead and transport decision here. If they have an altered mental status, they can't swallow, and so they can't take your oral glucose. Or if they can't maintain their own airway, they need to be transported. A lot of patients with diabetes are used to this. They've been around the block a couple times, and they're going to typically not want to be transported. So it's on you to decide if that's a good choice for them or not. And if it's not, figure out a way to talk them into it or to treat them appropriately. For history taking, we're going to ask a lot of questions about the chief complaint just to see where we're at with our patient. So you want to figure out your OPQRST, your sample, really talk to them about what's going on this time and what's different from other times if this has happened before. Oftentimes, like I said, patients with diabetes, they've been around the block. So they may know exactly what's wrong. They just can't fix it by themselves. They may know, I took my insulin, but I didn't eat. And so their blood sugar's low and now they're confused enough that they can't take care of themselves. Or I've eaten a bunch, but I didn't take my insulin. And now I know my blood sugar is high, but I can't do much for it. Once their blood sugar gets high enough, they have to bring it down in a controlled manner. So when they go into DKA, they are told not to take extra and extra and extra of their insulin because that could actually hurt them. So it has to be brought down relatively slow. You definitely want to observe for other physical signs and symptoms that have to do with high or low blood sugar with your sample history. If they know for sure that they have diabetes, you should ask them about the medication. Do you take insulin? Do you take pills? Do you wear a pump? Have you taken your usual insulin dose? Have you taken your pills today? Ask them about their eating habits for the day. Maybe they've eaten too much. Maybe they haven't eaten enough. And then when they have changes in their body, such as that from stress or an illness or more activity than usual, that can really, really mess with their sugars. When people have fevers, when they start exercising, or if they're just super stressed out, they can have high or low blood sugars that are not normal for them. So just, hey, is there anything out of the ordinary in your life recently? Have you been sick? Have you been doing a lot of exercise? Particularly stressed out more than normal? And a lot of times, if they've had this for a while, they know what's going on. We will go ahead and stop here and continue on in the next one.